here. And I must say I really enjoy the meeting, not only the high quality of the scientific session, but also the social activities. So thank you very much for the invitation and for the warm welcome. Mr. Chairman, ladies and gentlemen, incontinence has a severe impact on the quality of life of a patient. And even though high volume centers have a low incidence after radical prostatectomy, there are still low volume centers outside, and the overall incidence and number of radical prostatectomies that are performed is increasing. Thus, we are still confronted with incontinent patients, and I must say, to my experience, the number is even increasing. So what I would like to discuss to you are the surgical techniques to restore continence. When we go through the data, it's very difficult to compare because incontinence is completely differently defined and also measured. What I would like to discuss with you is the outcome of injectables, the different types of slings, the adjustable continence therapy, and the artificial urinary sphincter. I will not talk about bladder neck closure and Mitrofanoff or urinary diversion, because this is at least the last option we can offer. Starting with endoscopic therapy, these are the data on collagen, and you see that the dryness rate, and please remind that this is so-called social continence, not complete continence, whatever that means, are ranging between 10 to 42%, and you see that the follow-up is quite short, largest follow-up in the literature about 2 years, and you see that the complete continence rate is only 70%. There is another substance, macroplastic, and there is the only prospective randomized study that is available in this field, and you see that also the rate of continence achieved by injection of macroplastic is not very high, so it's ranging in between 12 to at least 80, but this was only in minimal incontinence, and the higher the degree of incontinence, the worse the results are. This was a very interesting study because it was investigated whether there is a difference in patient group getting an artificial urinary sphincter who had preoperative collagen or no collagen. At least you can do a sphincter after collagen injection. However, there was a significant time difference until the patient achieved continence. So you lose time and you leave your patient at least incontinent. Other substances that had been used, Other substances that had been used is carbon. These are the continence rate, however it migrates, and deflux, only very short follow-up. So at least to conclude, there was a committee on surgical treatment of stress incontinence in men in the year 2010, and they said that only modest success rates are available with low cure rates using endoscopic therapy. The effect tends to deteriorate over time, and this was level of evidence 3 and grade of recommendation C. There was recently a publication on the injection of myoblasts and fibroblasts, and this was quite promising. And you see that the continence rates were much better than with other injectables. However, there were concerns about the study, and the paper was withdrawn from journal. There are 2 interesting research papers on stem cell injections, but all were in rats. And you see there is at least a differentiation into smooth and striated muscle cells. However, there was the conclusion in current opinion in urology last year that as we have no clinical data, it currently should not be applied in a clinical setting. Let's switch to Proact. You may be familiar with the technique. These are balloons, and you can inject fluid, and so you can re-inject if continence is not achieved by first injection, and they are positioned in the area of this sphincter. These are the data that are out. You achieve dryness rates in the 60s. However, in some of these, only patients with mild or moderate incontinence were included, and the longest follow-up is now about 4 to 5 years. The major drawback of this technique is the complication rate, and you see that in 83% of irradiated patients, it fails. You need 88% of adjustments, and you have a complication rate that is comparable to the artificial urinary sphincter. However, your success rate is about 10 to 15% less. Again, this is mirrored in other studies that there is a decrease in the success rate in irradiated patients, and also complication rates are much higher. So the committee concluded it's feasible in the short and medium term for mild to moderate leakage. However, there is a contraindication, that is irradiation, and there is a need for multiple sessions and refilling. So at least no recommendation on the data available in the literature, because we have a variable complication rate ranging in between 12 to 58%, and that's even higher than the artificial urinary sphincter. So level of evidence, recommendation, grade D. We have different sling procedures available on the market. We have the facial sling, we have slings with bone anchor like the Invans, we have adjustable slings, and this is the most famous or common technique used nowadays, the transobturatoric sling. There's not much data on a facial sling. It was published in 1994 by Jochen Thüroff with a quite short follow-up and a success rate of 63%. And this was an interesting study. In these patients, the sling procedure was done at the same time as the radical prostatectomy. So there was an earlier continence in those patients who had a sling at the same time. Let's switch to the bone-anchored sling, and you see already from the mechanism that this is a kind of obstruction. It's not a functional mechanism. And this is one of the major problems of these types of slings. Here, the data available, and you see that the continence rates, and here continence is defined as no pad, is in between 36 to 65%. And there was a recent overview article last year in the British Journal of Urology, and you see here all the data published. And to summarize, the success rate is in between 40 to 88%, follow-up ranges in between 3 to 4 years at least, and there is an infection rate of 2 to 12%. One of the major drawbacks, however, are the complications like perineal pain, because you have to fix it to the bone. So it can appear in up to 2/3 of the cases, and as a sign of obstruction, you have newly developed detrusor overactivity, and you also have residual urine. What about the adjustable slings? And there are two different types, the Remix and also the Argus, where you use a silicone bolster, and you can readjust by just pulling on the sling. Again, these are the data available in the literature. You have a dryness rate of 30 to at least 79.2%. And I just would like to draw your attention on the number of adjustments. So you need quite a lot of adjustment in a majority of cases. Again, referring to the work of Welk and Hershon in the British Journal of Urology, success rate in between 72 to 79%, follow-up up to 4 years, erosions, also this is a type of obstruction, and we have also a small infection rate. Slings also, the success of slings also depends on the severeness of incontinence, and you see that in mild to moderate incontinence, results are quite good. In severe incontinence, the results get worse. And also in patients with irradiation, we have at least half of the success rate. Let's switch to the transobturatoric sling, and in contrast to what I've shown you now is that this is not an obstruction. The mechanism is to pull at least the urethra into the pelvis. That means restore the fixation, what we try with some of the operative techniques during radical prostatectomy. So the ideal patient is a patient who has a mild to moderate stress incontinence, needs less than 5 pads per day, loses less than 200 mils in a 1-hour pad test, and has, if you scope him, an intact sphincter's function. And when you reinforce by pressing on the perineum, then you should see an enhancement of the sphincter contraction. These are the data, and this is the current publication that is in press. It will be published in European Urology soon by the Munich group. They have now the longest follow-up with almost 3 years. And you see that the dryness rate is in the 50s with an improvement of an additional 20 to 30% of patients. There's only one publication who had really very bad dryness rates. So again, referring to the work of Welk and Hirschhorn, you have a success rate ranging in between 76 to 91 if you include the improved patients. We have now a follow-up. As I mentioned, there's one publication now with a 3-year follow-up, and you have a very low complication and explantation rate. But also in this group, there are some patients who fail, and Cornu investigated the failures, and he found that the failure was associated with previous urethral surgery, then with a high-grade continence, and at least irradiation. And some even reported a worsening of incontinence. This has to do with the positioning of the sling, so it's very important to make an intraoperative check by endoscopy whether you have the right place to put it on. So at least to summarize, slings have a continence rate ranging from 30 to 73%. We have bad results in high continence, a higher grade of incontinence. With increasing follow-up and after irradiation, there's some of these procedures that just cause an obstruction. And at least we work in the sphincter area, so we have bad conditions if you later on have to implant, for example, an artificial urinary sphincter. So what was the recommendation of the committee? In mild to moderate decrease of incontinence, it's a reasonable alternative. We need longer follow-up, and this was level of evidence 3, grade of recommendation C. Let's switch to the artificial urinary sphincter. The majority of people put a single cuff here in the bulbar area. There is one major drawback. If the patient is sitting on the perineum, then the fluid goes up here, and if he suddenly is standing up, he will lose his drops of urine. So this system is not a complete continence, and you have to inform the patient. And there is another major drawback. So if the patient is coughing, then there is a pressure transmission of the abdominal pressure to the bladder pressure, and if this is higher than the closing pressure, also the patient will lose drops of urine. We personally prefer the membranous position of the cuff because then the patient is not sitting on it. However, you should not do that if the patient has irradiation before or if he has a bad prognosis and need maybe irradiation afterwards, because if you put the cuff in this area, then you have a higher complication rate if the patient later on is irradiated. In those cases, we prefer a distal double cuff. You should put the cuffs immediately beside each other, otherwise you will get a diverticular information in between. I know that in the literature there is no evidence for a distal double cuff. This is just a personal experience of Professor Schreiter. I worked with him, and we published it only in a German language paper. So there is a last option, and this is the transcorporal cuff described by George Webster. This is only possible in patients that are impotent. You can put the cuff through the 2 corporal bodies. I will show you some results. So what is the outcome of the artificial urinary sphincter? This was an overview article of Tony Mundy's group. We have an overall continence of 73%, but we have a complication rate of 12%. And this is a publication of George Webster, and you see a quite high number of cases that the revision rate in this series was 21.4%, and the continence was quite high if it was the first implantation. If it was a revision, it at least was 82%, what's not too bad. The transcorporal cuff, data are a little bit worse. This is the series of George Webster, 84% of good results, and here in this series of Margera, 69%. I would like to show a little bit of our own data. This is from the hospital I formerly worked. We are a referral center, so these patients are coming from all over Germany. These are not Hamburg data. And you see that we put in sphincters in 269 patients, and we had at least a follow-up of almost 3 years. We used standardized PET test and a questionnaire to get some objective data, and you really see that the main cause for implantation of an artificial urinary sphincter nowadays is radical prostatectomy. The location of the cuff, as I mentioned, there is a switch to the distal double cuff due to the complexity of the patients we see nowadays, and this is the average of PETs in between 24 hours. Before surgery, it was average 7.4, and after surgery, it was average 1.3. And as I mentioned, they will lose some drops due to the reasons I explained. They are not 100% continent. The complications we only had in this 3-year follow-up a complication rate of 16.1%, and due to a very strict regimen, perioperative, we only had 1 early infection. Patients' happiness, you see the majority of patients are very happy or happy, and the same is true for the quality of life. It's significantly improved in the majority of our patients. These are our results on the transcorporeal cuff, only 15 patients, and you see that the continence rate is a little bit lower than it is with the normal artificial urinary sphincter. What other devices are available? That is a FlowSecure that is promoted by Tony Mandi. It has the advantage that there is an additional pressure regulating balloon. So when the patient is coughing, then the cuff gets an additional fluid from this pressure balloon. So therefore the number of losses or drops is reduced, however small number. This is a new device. We are currently working with this Swiss company MyoPowers. It's an electronic device. It works with a battery. And you see that we have here 2 cuffs, and they will close and open intermediately. So what we like to reduce is the pressure on a certain area, and thus maybe we can avoid an erosion. We just did cadaver studies, so we are ready now to go into a clinical trial. So to summarize, the artificial urinary sphincter is a dynamic system. It has no obstruction. It is suitable for all degrees of incontinence. It has the best continence rates. However, the patients need to be manual and mental capable to do it and to work with the device. And it has a high complication and reoperation rate, up to 36%. So the recommendation of the committee was it's the gold standard in severe post-prostatectomy incontinence. It's feasible even after external beam radiation. The success and patient satisfaction outweigh the need for periodic revision, and this was level of evidence 2, grade of recommendation B. So to summarize, injection therapy has bad results and you lose time. Myoplastic fibroblasts, paper was withdrawn. We need long-term results. Proact has a high complication rate. It's contraindicated in irradiation. Slings are an option for mild to moderate incontinence. We need long-term results. And the artificial urinary sphincter remains, at least for the severe incontinence, the gold standard. Thank you.
Thank you. Beautifully clear. Thank you very much. Any questions? Yeah.
Margaret, nice presentation, and you showed actually everything, every different device that's available. At the EAU this year, they showed an improvement of the Proact system. And the improvement is that you can actually stick in with this device where you puncture it, you stick in a wire, and over the guide wire you can place the balloons, which makes sense in one way or the other, because sometimes they move to the right or to the left. The question is, do you still work with the Proact system, or do you just skip it and you just do the XP, the advanced XP, or the sphincter?
Yeah, I personally don't like the Proact system because, as I showed, the complication rate is as high as the artificial sphincter and the success rate is 15% lower. So when I treat patients, the first surgery you do should be the best. So it's very important to have a good patient selection. So I either do a sling, and I do the transobturatoric sling, and I really highly select the cases, or I do an artificial urinary sphincter. Because we see so many patients who went through all these procedures, and then they come with you, and you can't put a sphincter, a cuff around the bulbar or membranous urethra, because they had injections, they had a sling, they had Proact. Yeah? So you are left with the distal double cuff, and then the last option is the transcorporal cuff, and that's the reason why I'm not a fan, and I don't like the Proact system.
Can I ask about the outcomes? So after surgery, a pad-free status is, I think, an appropriate outcome. Most men don't use pads before surgery. But after all your interventions, you were quoting dryness rates. But in fact, the therapeutic objective is to get patients to one pad. Your mean was one pad. And I think, wouldn't that be a more appropriate endpoint?
The problem is that the use of pad also is different from patient to patient. There are some patients, they change the pad if they had a drop in it. There's another patient who's just changing the pad if it's really full of fluid. So, and this makes the problem to really define continence and to compare these data. What we did is we in our series, we defined continence as using one pad because it's a security pad, and that's what most of the patients with the sphincter also need.
Thank you. Okay, well, Vincent, you started, I couldn't possibly stop you, but you'll be the last question. Yeah.
It's not a question, it's just a remark. Please teach your young physician and emergency department to be aware about the artificial sphincters. We have 2 cases in Switzerland where a patient having these marvelous techniques and they are happy. The manchette was destroyed by a forced catheter.
Sure.
So please train your young physician.
This is very important. The majority of complications of erosions we see nowadays is to put in a catheter or to scope without really deflating and deactivating the system. And even though the patient is telling the nurse, please don't do it, I have an artificial sphincters, I know what I'm doing, and then he has the erosion. So it's very important.
Okay, on that note of caution, we're going to end. Could I thank the speakers? It's been a fantastic 2 sessions.